So hello friends, now after discussing the zygomycosis, we are with aspergillosis. Okay, so in this video we are going to discuss about aspergillosis. So let's start our discussion on aspergillosis. So aspergillosis basically refers to invasive and allergic disease. Okay, it refers to invasive and allergic disease which is caused by a hyaline mold that is known as Aspergillus. You are knowing, okay, that is known as Aspergillus. So aspergillosis refers to the invasive and allergic disease caused by a hyaline mold named Aspergillus. Now next point, that there are nearly 35 pathogenic and allergenic species of Aspergillus. Important one which we are discussing, that is Aspergillus fumigatus. Okay, then your Aspergillus flavus, then Aspergillus niger. These three are important. So we will mainly focus on Aspergillus fumigatus, flavus and niger. Now coming to the pathogenesis after general introduction. So Aspergillus species are widely distributed in nature, most commonly growing on decaying plants, okay, producing chains of conidia, and transmission basically occurs by inhalation of airborne conidia. Okay, and risk factors for these are glucocorticoid use, okay, because of the immune suppression of glucocorticoid, and this is the most important risk factor. Okay, glucocorticoid is the most important risk factor for aspergillosis. The next is your profound neutropenia. Okay, the next is your profound neutropenia. The third one is your neutrophil dysfunction. Okay, the third one is your neutrophil dysfunction. Then underlying pneumonia, okay, or anti-tumor necrosis factor therapy. Okay, anti-tumor necrosis factor therapy. So these are some important risk factor. The glucocorticoid use is the most important risk factor. Then profound neutropenia, then neutrophil dysfunction, then pneumonia, and the last one is your anti-tumor necrosis factor therapy. So these are the important valence factor, okay, which you have to look for. Then coming to the next part, that is your clinical manifestation. Coming to the clinical manifestation, that is also very important. Okay, generally asked in your examination. So starting with the clinical manifestation. So the first is your, first we will discuss incubation period. Okay, so incubation period is basically 2 to 90 days. Okay, 2 to 90 days is its incubation period. Now first type is your pulmonary aspergillosis. Okay, the first one is your pulmonary aspergillosis. So it is the most common form. Okay, I will write full, that is pulmonary aspergillosis. So it is the most common form of aspergillosis and includes various manifestations such as your ABPA, okay, that is allergic bronchopulmonary aspergillosis, then bronchial asthma, then extrinsic allergic alveolitis, okay, asthma, alveolitis, ABPA, allergic bronchopulmonary aspergillosis, then your Aspergilloma, then acute angioinvasive pulmonary aspergillosis. Okay, acute angioinvasive pulmonary aspergillosis, then your chronic cavitary pulmonary aspergillosis. So these are the pulmonary manifestation, starting with your allergic bronchopulmonary aspergillosis, asthma, then your extrinsic allergic alveolitis, Aspergilloma, acute ABPA, and chronic cavitary pulmonary aspergillosis. The second one is your other forms of aspergillosis, such as your invasive sinusitis. Okay, invasive sinusitis will be there. Then cardiac aspergillosis will be also there. Endocarditis and pericarditis is caused. It is important MC question. Okay, endocarditis and pericarditis. Then cerebral aspergillosis, brain abscess, hemorrhagic infarction or meningitis can occur. Then ocular aspergillosis, keratitis and endophthalmitis will be there. Then your ear infection, otitis externa will be there. Then cutaneous aspergillosis, direct invasion of the skin in neutropenic patient at the site of IV catheter insertion, okay, and bone patients. Yeah. So these two are very important. That is cutaneous aspergillosis due to the direct invasion of the skin occurs in neutropenic patient at the site of IV catheter or in bone patient. Now coming to the next, that is your H, nail bed infection, okay, and last is your mycotoxicosis. Okay, so these are the clinical manifestations. Okay, so pulmonary APA, asthma, alveolitis, aspergilloma, acute APA, okay, and we have also discussed invasive sinusitis, cardiac aspergillosis, cerebral aspergillosis, ocular ear infection, okay, then your cutaneous aspergillosis, then nail bed infection and mycotoxicosis. Now moving to the next one, okay, that is your clinical manifestation. And more important point, that is clinical manifestation also depends on the species involved, such as Aspergillus fumigatus, it causes acute pulmonary and allergic aspergillosis. Flavus is more common in hospitalized patient, and Niger can cause invasive infection, but more commonly colonizes the respiratory tract and causes otitis media. So species are also there. Now coming to the last important point, the lab diagnosis. So a specimen such as sputum, tissue biopsy can be collected. Then we will examine directly. There will be direct examination. In that, KOH 10% KOH mount, okay, or histopathological staining of a specimen reveals your characteristic narrow septate hyaline hyphae, okay, with your acute angle branching. So this is important MCQ question. That is narrow septate hyaline hyphae, or narrow septate hyaline hyphae with acute angle branching. Now the next is your culture. Okay, so specimens are inoculated on SDA and incubated at 25 degrees centigrade. Okay, species identification is done based on macroscopic and microscopic appearance of the colonies. Okay, we will discuss the macroscopic and microscopic later on. Okay, so colonies consist of hyaline septate hyphae from which coniospores arises, which end at vesicles. Okay, the next, that from the vesicles, finger-like projection of conidia producing cells arises called as phyalites or sterigmata, and these phyalites are arranged either in one or two rows. The first row is known as medullae. Okay, so this phyalites, then sterigmata, then your medullae. Clear? After this, we can do antigen detection by ELISA, and we will detecting Aspergillus specific galactomannan antigen. Okay, this is specific for Aspergillosis, that is galactomannan antigen. Which antigen? Galactomannan antigen. So this is important. Then we can do antibody detection. Okay, then after antibody detection we can detect metabolites. Okay, metabolite detection can also be done, and here detection of beta 1,3 D glucan, okay, by G test. This detectable beta 1,3 glucan is detected by G test, and it is useful alternative for establishing the diagnosis, particularly when the culture is negative. And the last, we can also do skin testing. Clear? Now coming to the one important point of lab diagnosis which I have left. I told you I will discuss later on. Okay, so coming to that, first, that is your colonies. Okay, Aspergillus fumigatus. So macroscopic appearance of colonies like a smoky green, velvety to powder. Okay, clear? And scopic. The vesicle is your usually conical shape. Okay, so fumigate is a conical shape vesicle, and phyalites are arranged in a single row. Okay, so coming to phyalites, so it is arranged in a single row. Clear? Now the next is your Aspergillus flavus. So macroscopic, it is yellow green. Okay, velvety. And then your microscopic vesicles are here globular shape. Okay, vesicle is globular shape. Here vesicle is your conical shape. Here your globular shape. And phalicets are arranged in 1 and 2 rows. Okay, so this is the basic difference. Okay, so thank you for watching. Best of luck.